Hello, everyone, and welcome to Got a Problem with Your Knee? Ask Dr. P, a forum where everyone could ask questions about knee pain, knee arthritis, or other joint pain. So, obviously, today we have Dr. Pietropaoli, board certified orthopedic surgeon, sports medicine specialist, and regenerative specialist. So today we have some questions that were submitted ahead of time, and anyone who hops on, feel free to ask some questions. So Doc, if you want to go ahead and throw on your camera, we'll get started here. How you doing today?
Hey, great, great. Thanks for the intro, Adam. Appreciate it. Thank you, everybody who's out there. Appreciate it.
Sweet deal.
Looking forward to some
Having a
questions.
little issue with volume. Cool. All right. So first question, submitted by a someone on our Facebook group. Um, what is a main, what is the main cause of arthritis?
What's the main cause of arthritis? I think the answer to that question first would have to be answered by what is arthritis? So arthritis is nothing more than the cartilage on the end of the bone wearing down. All of our bones have cartilage, kind of like the tread in a tire. And so when that wears down, that surface, that tread wears down, that's what arthritis is. Now, there's a lot of different causes. I think the most common cause is your osteoarthritis, which is wear and tear arthritis. Over the years, just like a tread on a tire, our bodies don't have the ability to repair ourselves as well as we used to. So little by little, the cartilage on the end of the bone wears down, and that's some of that has to do with genetics. Some of us get the Michelins, some of us get the Kmart retreads, and most people get stuff in between. So some of that has to do with genetics. Some of it has to do with your own, wear and tear, how you beat your body up. If you're overweight, your diet. So exercise, there's a lot of different factors, but the number one cause of arthritis is osteoarthritis. Now, there's also rheumatoid arthritis, where your body attacks itself. It's an autoimmune disease. So our bodies, unfortunately, sometimes can attack ourselves. And there's all kinds of different autoimmune diseases. Lupus is one of them. Psoriasis or psoriatic arthritis, rheumatoid arthritis. Those are all autoimmune diseases that can attack the lining of our joints and thereby also the cartilage in our joints by causing too much inflammation. You can have an infection in your knee. If you unfortunately get an infection in your knee, the infection can break down the cartilage and that can wear down the tread earlier than it would normally wear it down. So that can cause arthritis. That's kind of post-infectious or what we call post-traumatic. Post-traumatic, meaning after an injury, would also be something like playing football in high school, tearing your ACL, tearing the shock absorber cartilages, because in the knee you have the meniscus cartilage, which is the shock absorber cartilage, and then you have the cartilage on the end of the bone, which looks like the white on the end of a chicken bone. And like we just talked about, the tread on a tire. Those meniscus cartilages are shock absorbers and they protect the cartilage on the end of the bone. So if they tear, that can cause increased wear and tear, and your knee to wear out faster than it would if you hadn't injured it. Also, if you tear your ACL or one of the main ligaments in the knee and the knee is unstable and it's giving out all the time, that excess pressure and all the micro injuries and injuries, repetitive injuries from it giving out can cause that tread to wear down. So that's called post-traumatic arthritis. Um, there's some other things that can cause it, like gout is kind of like an autoimmune disease, but it's not really an autoimmune disease. It's more of a metabolic disease where you have too much uric acid in your bloodstream, and uric acid comes from eating proteins and things like that. So, but number one, most common cause of arthritis is osteoarthritis, wear and tear arthritis.
Gotcha. Thank you. And I think the next question really kind of fits nicely with the explanation that you just gave, which is, can osteoarthritis improve or get better? Can it be reversed?
All right. Another great question. So, as we just talked about, osteoarthritis is generalized wear and tear on the cartilage on the end of the bone, which again is kind of like the tread on a tire. And so when that cartilage wears down, in general, and definitely traditionally, there's been no way to grow it back. Once it wears down, it wears down. And I would also say that our cartilage has cells in it. They're called chondrocytes. Okay. The chondrocytes are cells. Our body's made up of billions and trillions and gazillions of cells. And so there's specialized cells that make cartilage. So cartilage is not only composed of cells, but it's composed of a matrix. So, people who eat glucosamine, chondroitin sulfate, those fancy, supplements those long names, glucosamine and chondroitin sulfate are just two components of the matrix of your cartilage. So the entire cartilage isn't a bunch of cells. It's little cells and these little like honeycomb lacuna, they're called. So the cells are in there and the cells produce the matrix or the tread. And so once you lose those cells, we don't have a really good way of getting new cells back. When you lose some of the matrix, it's also hard to get that matrix to come back. But if we do things that can improve the function of those cells that you still have left, they will produce more matrix and you can grow some matrix back. So you can grow some new cartilage back using biologic treatments like bone marrow aspirate, which has stem cells. It has other cells that help the stem cells. Some of those stem cells might turn into cartilage and retread your tire, but not a lot of them. And it's really more those cells go in and they tell the other cells what to do. So they tell those chondrocytes to produce more matrix and hence hopefully thicken up or at least slow down or stop the progression of the wear and tear. So, and a better answer to that question is, can we reverse it? Not a lot. We can maybe a little bit. Can we halt it or slow it down? Absolutely. Absolutely. And then that not even just with the cartilage, there's the underlying bone, there's losing weight, there's the right diet, anti-inflammatory diet. There's a whole bunch of reasons and things we can do to slow it down or halt it. But we don't have great ways of taking what you had lost and making an 81-year-old knee look like an 18-year-old knee, for instance. Now, I think we'll get there at some point, but I think the bigger thing is going to be genetic therapy to slow down the progression or prevent arthritis in the first place, and also education, like what we're trying to do. We're obviously trying to prevent the need. Our mission is to prevent the need for knee replacements by the year 2043. So yes, knee replacement free by 43. That's kind of what our mission is. Not kind of, that is our mission. And so the best way to do that is not to treat people when they get to the point like, they have arthritis already. We want to prevent the arthritis in the first place. And so it's a really big mission and it starts with prevention. And then there's also treatment. And then there's also maybe regrowing and all kinds of genetic treatments and other things out there that are on the horizon. A lot of things we don't even know exist or will exist in 5 years, but they will, because that's how technology is improving, especially with AI. So that's a long-winded answer, but the bottom line is we can't reverse it a lot. We can reverse it a little, but we can definitely slow it down and halt it and make it feel better and make the cells that you still have left work a lot better. And that makes a huge difference in how you feel and how you achieve your goals.
Absolutely. One thing that you touched on there was weight loss. So this isn't necessarily a question that was submitted, but I want to have you expand on it a little more. How does weight loss affect arthritis?
So, when we walk, we land with about 3 or 4 times body weight. That's a little controversial. People get all, they get all excited about how much weight we actually land with when we walk. And, if we go up and down stairs, it might be 5 to 8 times body weight. If you start running and jumping, it might be 10 times body weight of force going across your lower extremities, including your knees, which we mostly talk about knees here. And so any way we can lessen that force going across those knees is going to do a few things. It's going to hopefully slow down the wear and tear. It's going to make your symptoms feel better. And it's also going to, what was the exact question again? Because I want to frame it back to that. How does weight loss do what?
Affect arthritis.
Okay. So people who are obese, and this is a little bit controversial too, is as far as the exact number, but somewhere around 60 to 70% of people who are obese develop arthritis. Okay, they're more likely to develop arthritis. And about 70% of people who get knee replacements are overweight as well. So that just tells you there's a big, strong correlation between um, being overweight or obese and are developing arthritis. So, and it makes sense, right? The heavier you are, the more force is going to go across your joints. Now, you can counteract that in a few ways. One is by losing weight. The less weight, the less force. And, it multiplies by 3 or 4 when you're walking. So if you lose 10 pounds, that's 40 pounds less weight going across your joints. Imagine, just carry a 30-pound weight around for a day, and you'll see how much extra force that is going across your joints, that even if you lose just 10 pounds, you're gonna drop that off. And then the other way is losing weight and then strengthening your muscles because your muscles are your main shock absorber. So if you have weak muscles, they're not going to absorb as much force. And then more and more force is going to get transmitted to the bone underneath or even to the cartilage, and it's going to wear down faster. We'll get into the bone. The bone's a whole nother issue that we can get into if you want to get into that. So losing weight and increasing muscle strength and muscle mass because it's not as much sometimes about losing weight. You can increase your muscle mass and gain some weight, lose fat, which is good for your overall health. And even though you gained a little bit of weight and muscle, you're going to have less force going across your joint because your muscles are going to absorb more of that force. So they go hand in hand. You don't want to just lose weight and lose muscle mass because then your muscles are going to get weaker. You're not going to get as much benefit. You kind of want to do both, but the exercise and increasing your muscle strength is massive. Now, the other is what you eat. You are what you eat. And if you eat food that is fried food or food that's going to just cause inflammation, sugar, refined sugar, anything that's going to cause inflammation in your whole body is going to cause inflammation in your joints. And inflammation wears down your joints. That's the bottom line. And so if you can eat a less inflammatory diet, that is going to also theoretically lessen the risk of that cartilage wearing down. It's going to make your knee feel better because it's not inflamed, because inflammation causes pain. And if you eat the right building blocks as your body breaks down, because every day our body breaks down a little bit and then we go to bed at night, and I'm simplifying things here, but then we repair ourselves and we wake up in the morning and we keep going and we don't fall apart. As we get older, that repair process isn't as good, and we have ways at Victory in Motion, home of knee repair, not knee replacement, to be able to help your body heal itself better as you get older. And we can help boost that in certain ways. But even into your 80s, you're still repairing yourself. And so by giving yourself the right building blocks to repair yourself, you're going to not break down as fast. So people who eat really good diets, people who maintain muscle strength, people who maintain a healthy weight, they tend to not have arthritis. And if you go to Japan or Asia, in those areas, the prevalence of arthritis is much, much less, at least in the extremities, lower extremities.
Yeah, for sure, for sure. So, and you definitely touched on another question that we have was what foods can worsen or trigger arthritis pain. So, inflammatory foods essentially, right? So, I think that's awesome. Let's see.
Well, so I'm going to flip it back to you, being our V-Slim and our genetic nutrition expert in the clinic. Um, Why don't you talk a little bit about that, the genetic-based nutrition, and then some anti-inflammatory foods? And it depends on your genetics as to, in some ways, I mean, sugar pretty much universally, right? Alcohol universally. There's certain things that are universally inflammatory, but not everything that's anti-inflammatory for one person is going to be anti-inflammatory for another person. So maybe why don't you touch on that? Because that's really more your expertise. Not that I don't know anything about it, but go for it.
Yeah. So, at Victory Motion, home of knee repair, not knee replacement, right? A part of that knee repair, not knee replacement program is genetic-based nutrition. Now, there has been several studies, one famous one out of Stanford that showed that when you test people's genetics and give them a nutrition plan based on their genetics versus just a vague plan, the people who get the genetic-based nutrition plan lose exponentially more weight compared to the people who are just getting a generic plan, right? So a piece of what the the genetic test looks for is what foods are likely to be pro-inflammatory in your body. So some of those foods include, gluten, lactose, um, some oils, right? There's a ton of
Yeah,
oil
seed oils,
that
right?
cause inflammation in the body. I always like to tell people about my experience with gluten. I found out that that is something that inflames me. As soon as I got that out of my diet, I had less muscle soreness after exercising. I had, less gastrointestinal issues, all sorts of stuff like that. But it just goes to show that your genetics play a role, like where you're from, where your lineage is from, play a role in what foods may cause inflammation and what foods may lessen inflammation. So to kind of sort through all of that without just guessing and checking, getting a genetic test is super important to nail down exactly which foods will react well with your body and your genes, right? So that's an overview of the program that we have here. Obviously, there's, supplementation is part of that and, you know, um, behavioral changes. But that's a big piece of it is understanding exactly what's going on in your body, what your body wants, how your body is going to lose weight based on what you take in, right? So um, that's,
Yeah, that's a simple, just a mouth swab that
yeah,
gets sent off to the lab, and then I did it myself, as you know, and you get like a 32-page report. If you want to geek out, you can read it. But the cool thing is that we have people like you, and we have some diet nutrition experts who will be your coach for 3 months to interpret that, and you don't have to interpret it if you don't want, and they will help you figure out what the best foods are based on your genetics to decrease inflammation, which will help your joints, including your knees, and hopefully slow down, if not at least mitigate the symptoms of the arthritis. But also, I mean, we've had plenty of patients. I'm not guaranteeing this, and this isn't medical advice, but we've had plenty of patients they've decreased the inflammation in their body, which we know can lead to cardiovascular disease. It can lead to diabetes, can lead to cancer. It can lead to all kinds of bad things. Obviously, inflammation in our joints, right? What we deal with all the time. But we've had people get off their blood pressure, their cholesterol, their diabetes, and their heart medications, all because they changed their diet to an anti-inflammatory diet. They lost fat, which fat causes inflammation, and they lost weight, or even if they didn't need to lose weight, they put on lean muscle, which burns more fat and also cushions your joints and also makes it less likely to have this overall inflammation in your body and joints. So it's pretty amazing that we've seen people literally, their primary care takes them off their medications, and now they're saving $500 a month on copays that they were paying for all those expensive meds. So it's pretty amazing.
absolutely, for sure. Um, Next question. Can running cause arthritis?
Well, it's a great question, especially since I am a runner and love to run, and I know you do as well. And I've run 7 marathons, and someday you're going to run a marathon for sure, right?
No, I stick with the halves. I'm good.
Come on. Anyway, yeah, great question. So there are no I get asked this question all the time. There are no known definitive studies that show that running in and of itself causes arthritis. None. Now there's a couple studies, if I recall, that might show that people who ultra marathoners might be a little higher risk. But there's really no definitive studies that show that running causes arthritis. Now, once you have arthritis, meaning that tread is wearing down, um, there are a lot of people that we have who have arthritis who still want to run. So there's ways around it, especially I have my runner's personality and I also have my doctor's personality, or my runner hat and my doctor hat, and they have to meld together sometimes when I'm talking to runners, because they're difficult patients. We are. But uh, running isn't the best exercise in the world if you have arthritis. If your cartilage is already wearing down, there are some studies that show that it could potentially wear down faster if you already have arthritis. But again, that doesn't mean you can't run for sure. It's not the most doctor highly recommended exercise to do, but there are people like ourselves who just love running. And so we will work with people to try to get them back running. We may have to modify things. There's a lot of things we can do. But in general, there's no studies that show that running causes arthritis.
Excellent. Um, what about cycling? Does cycling help arthritis?
It all depends on what they meant by help, but it definitely can help the symptoms. Now, it's not necessarily going to grow new cartilage back. Having said that, when movement is good, movement is medicine, movement is really good. Movement is longevity. So anything where you're moving your joints is going to um, improve the health of your joints. So if you just put someone in a cast and they don't move their joint, the joint starts to degenerate. So joints were made for moving. Now, sometimes when people are in pain or they've had injury, they don't want to move their joint. That's where our VFit specialists and that's where PTs and ATCs and certified strength and conditioning specialists and fitness trainers and all that. That's where they come into play to keep it moving, but not overdo it until it's healed, where we can get it back to normally moving. So what I'm getting to is cycling is obviously moving. And that's just healthy for the joint no matter what. And so it's not going to grow back new cartilage. It's not going to cure arthritis, but it is going to keep the knee as healthy as possible to hopefully slow down the progression of the arthritis. Because as your joint fluid moves, it actually our joints have fluid in them to lubricate them. So you have the cartilage in there, which we just talked about. Then you have fluid in there too. And that fluid is actually how our cartilage gets its nutrition. Cartilage doesn't have a good blood supply, so it doesn't get its nutrition from the blood, which is one of the reasons why it doesn't heal when it's injured, because it doesn't have a blood supply, so it can't heal. So it can only really heal by or it only gets its only nutrition. It gets its nutrition from the joint fluid. And so movement helps the joint fluid be a better quality, and that keeps your cartilage in better shape. So cycling is going to maintain, it's going to help strengthen, so that might help slow down the progression of arthritis. It's going to decrease symptoms. It's a tremendous exercise. If you can't run or impact load, jumping, running, cutting, those types of things because of arthritis or whatever reasons, cycling is amazing. It's one of the first exercises we get people doing on an exercise bike after a surgery, right? So it's a very good exercise to do, but it is not going to cure arthritis or reverse arthritis in and of itself. Does that make sense?
Absolutely. Yeah. And especially being in a lesser impact loading position, that's, super helpful. Does drinking water help with arthritis pain?
These
AKA
are
being
these are good
hydrated.
questions. Yeah, yeah, yeah. No, no, no. Hey, drinking water is being hydrated is huge. I mean, our joints have fluid. We just talked about this. Our joints have fluid. So if you don't have good quality fluid because you're dehydrated, or you don't have enough fluid because you're dehydrated, I'm simplifying things here a little bit. But if you don't, the bottom line is you're not hydrated enough and your fluids aren't good enough in your whole body, it can affect your body and it can definitely affect your joints. So being hydrated improves the quality of your joint fluid, and that improves the quality of your joint. Being hydrated is not going to cure arthritis. Is it going to help your symptoms? Sure. Anything, even just general inflammation in the body, the more hydrated you are, the more it's going to wash that inflammation out. Now, you can also, you don't want to go crazy. You can drink too much water, and then you get a thing called hyponatremia, which means not enough sodium, and it can cause seizures and all kinds of issues. And I mention that because some runners and some cyclists who we were just talking about, if they're exercising for over an hour, 2 hours, 3 hours, 4 hours, running marathons and things like that, and they drink only water or they overdrink water and there's not enough electrolytes in there, you can have issues with that as well. So, I mean, your 8 to 10 cups of water a day, I'm sure you have a formula in your head how many pounds somebody is to how much water they should drink per day. What's your formula that you use?
You know, um, there is a formula. What I've, yeah, I think it's like, I don't remember the exact formula. There is a formula. Here's why I say this, because the best way that I tell people to ensure that they're hydrated, make sure you're peeing clear. That's the easiest thing
Exactly.
for everyone to keep up on, everyone to see, okay, I am optimally hydrated. Um, so that is coming from a athletic trainer background where I would work with a bunch of athletes who had no concept of being hydrated. That is the easiest way to convey that message. Obviously, you do have the concerns about hyponatremia and all that. If you're eating a well-balanced diet for the most part, you're going to avoid that. Of course, there's also the addition of, electrolytes and things along those lines that if you're going for over an hour, I would generally recommend that. But you're right, there is a formula. I have personally moved away from the formula just because there's an
I,
easier
I'm
way
not
to.
a I'm not a huge fan of that either. I agree.
Yeah. So, um, why is my knee pain worse in the morning?
I think that goes along with what we were kind of just talking about. If we put someone's knee in a cast and it doesn't move, it starts to degenerate quickly and it gets stiff. So during the night, some people move more than other people, but in general, you're not moving much. And so when you don't move, your joints tend to get stiff. So that's why when you break your wrist and you're put in a cast, you come out of that cast and that wrist is stiff. It's not necessarily that you broke it that it gets stiff, it's that you were put in a cast. If we put your other wrist in a cast, you would come out stiff as well. So again, movement is and motion is healthy. That's medicine. And so it's basically most of the time because you haven't really been moving and you get a little stiff. Just like when a cat gets up from a cat nap, they got to stretch out to kind of get going again. Now, also, that's exacerbated or made worse if you have arthritis. So if you get older, you find, hey, it might even take even longer. That's because when you have arthritis, it does take a little longer to get that joint warmed up. And I don't think anybody knows the 100% physiologic reason for that. But the bottom line is when you have arthritis, it does take longer. Your joints are stiffer. And so in the morning they're stiff and they're painful. You get moving, and once you get moving through the day, they don't feel maybe as bad. And then at night, after moving all day, they're kind of swollen and inflamed because there's arthritis in there, and then you notice it a little bit more. And that's kind of the cycle of how arthritis usually affects people. So in general, all of us are a little stiffer when we wake up in the morning because we haven't been moving. And if you have arthritis, it makes that even worse.
Gotcha. Yeah. Um, compare and contrast. This is a three-part question, so it's going to be a good one. Cortisone, gel shots, and PRP in terms of osteoarthritis at the knee.
Okay. So cortisone. Cortisone is it is a natural substance we have in our bodies, cortisol, cortisone, or some form of that. And it's made in our adrenal glands, which are right above our kidneys. So it's a normal hormone. It's a normal anti-inflammatory in our bodies. Now it's made artificially in factories and things like that nowadays. So the cortisone you get out of a bottle is not it's not natural. It's made and it's also chemically altered. It's not exactly the same cortisone that we have in our body necessarily. But and there's varying forms of it. But the bottom line is cortisone is an anti-inflammatory. So if you have inflammation, swelling, inflammation, um, it can decrease inflammation. It does a good job of that. That's the only upside in my mind. The downside is cortisone can damage tissues. You get one shot in your joint, it's not going to destroy all the cartilage in your joint. But there are plenty of studies that show that you get repeated cortisone injections. So patients, there's a couple studies just within, I think 2022, they came out, two specific studies. There's a bunch of other ones too. But in 2022, there were two studies that came out and they looked at patients who got cortisone injections in their knee versus patients who didn't. And the patients who got the cortisone injections in their knee, their arthritis actually progressed and developed faster than the people who didn't get the shots. So it's a temporary fix. You're kind of playing with fire because if you get too many of them, it's gonna damage your knee and make it worse. And so what you're trying to do is get your pain better, and maybe it helps get the swelling and the pain better, but you're gonna have to pay the piper down the road because your cartilage is gonna wear down faster. Not to mention cortisone can increase blood sugar. If you're a diabetic, that can be a problem. It decreases healing. So if you get a cortisone shot in your knee, for instance, we don't like to do surgery if we don't have to anyway, but we don't like to do surgery for at least 6, 8 weeks after the cortisone shot because it increases the risk of infection. Who wants that? It also can damage the cartilage, like I said. It can also affect wound healing. And so if someone had a cortisone injection in their shoulder and then they had surgery, the wounds might not heal as well, but also the rotator cuff tendon might not heal down to the bone as well. And that can even be like in the shoulder with a rotator cuff. If someone gets a cortisone shot, uh, they have a 25% chance more of not healing or re-tearing than if they didn't get a cortisone shot within a year. So it might be 11 months ago you got your cortisone shot, and now you have your rotator cuff surgery, and you're still at a higher risk of either not healing or failure, which is crazy. So cortisone has a lot of detrimental effects, and it's a band-aid, and it's not getting to the root problem. Gel injections are basically what we were just talking about. All our joints have fluid in them, right? And so as we get older and as we get arthritis, the fluid thins out. It's not as good of a lubricant as it used to be. So they make these artificial joint fluid injections, which actually originally came from the rooster comb, that little red thing on the top of a rooster. And they're made out of, there's hyaluronic acid in those rooster combs. And our joint fluid, the main composition of it is hyaluronic acid. And you may have heard of hyaluronic acid. It's in all kinds of cosmetics and makeup and all kinds of stuff nowadays. So, but it's the main component of our joint fluid. So we inject with a needle these artificial joint fluid shots into the knee, and it thickens up the fluid, kind of like a motor oil change. But what it also does is it stimulates your joint to produce better fluid. So it tends to last longer than a cortisone shot. Maybe a cortisone shot on average is 6 weeks effectiveness. And on average, the gel injections are 6 months. Now, there are different versions of that as well, all kinds of different versions. There's a 1 shot version, there's a 2 shot version, there's a 3 shot version, 4 shot version, 5 shot version, once a week for X amount of weeks. But they usually, once you get done with either the shot or the series of shots, it's going to last on average about 6 months. It's not going to do harm necessarily to your knee, although anytime we stick a needle in anybody anywhere, no matter what we do, there's always a slight risk of infection, but it's very low. So it's not necessarily going to do harm, but it's not going to fix the root cause of the problem. And if you have a bone problem, it's not going to take care of that. I have been alluding to the bone problem here. We probably should get to that at some point, even if someone didn't ask the question, because they probably didn't on
Yeah.
that. Now, PRP. PRP is platelet-rich plasma. So it comes from the platelets in our blood. Our blood has platelets. The platelets are those things that when you cut yourself, they come in and they form a scab. A whole bunch of platelets come in, they form a scab, they stop the bleeding, and you don't bleed to death. So that's the one positive thing that platelets do. But platelets also have growth factors. So they release the growth factors, and those growth factors stimulate new blood vessels and cells to come in the area. So these growth factors are basically like rocket fuel to help with the healing. So now, what if we take a bunch of blood, and not a ton, not as much as you would take even from like a normal blood donation, which might be 300 cc's, like a pint. Okay, it's 60 cc's compared to 300 cc's, so it's on average. And so you take a little bit of blood, we spin it down in a centrifuge, which is kind of like a washing machine, and the red blood cells, the white blood cells, the platelets, the fluid, the proteins, they all separate out because they have different weights. The platelets are a little white layer. We take the platelets out, the concentrated platelets, and we'll inject them into areas of the body that we want it to try to get to heal faster. Because remember, it's like rocket fuel or jet fuel for healing. It has growth factors. So we're concentrating all these growth factors, and in the instance of the knee, injecting them into the knee to stimulate the knee to heal itself. It does not grow back cartilage either, PRP, but it does help the inside of the joint heal and work better. And it does tend to last longer than a cortisone shot or gel injection. So on average, probably, and when I say on average, it's probably like 80% of people get a cortisone shot, it lasts 6 weeks. 80% of people who get gel injections, it lasts 6 months. 80% of people who get a PRP injection, it'll last a couple of years. Some people last a lot longer, some people won't last quite as long, but it's on average, it's about 2 years, 80% chance of 2 years. Now, the cool thing about PRP is we're using your own body to heal yourself. This stuff isn't manufactured in some lab or some factory. It's not artificial. It's your own blood. We're just concentrating it. So that's the amazing thing. That's like I said, our bodies have this ability to heal ourselves. As we get older, it's not quite as good. And so we can take our blood and concentrate it and help our body heal itself a little bit faster. When you're younger, the PRP tends to actually be even stronger. So in a teenager who tears something or sprains something, it works really amazing. As people are 30s, 40s, 50s, 60s, 70s, 80s, etc., it may take more than one injection to notice the full effect. Maybe one, two, three. Especially if we're dealing with a tendon, which a tendon attaches muscle to bone, like at the elbow for a tennis elbow, it may take a couple, three injections if you're older. But for a knee, a lot of times one injection might even last a couple of years. And so, like I said, it's not going to grow back new cartilage. It's not going to cure the arthritis, and it's not going to take care of if there's a bone problem in the knee.
Well, let's talk about the bone problem.
There we go. Okay, so we have the cartilage on the end of the bone, which is kind of like the tread on a tire. I've said that a bunch of times here, but you have to visualize that. And then underneath the cartilage is bone, because the cartilage is on the end of our bones. And so that's called the subchondral, below the cartilage bone, the subchondral bone. If that bone starts to get soft as we get older and our body doesn't heal itself as well, and we start to break down faster than our bodies can heal ourselves, or we're overweight, or our muscles are weak, or genetically we have an issue. If that bone starts to get soft, think of it like a road too, like the surface of a road. You have the asphalt, which is kind of like the cartilage, if you think of it that way, to use a different analogy. And then you have the underlayer of the road, the stone, all the packed stone, all that stuff. That's like the bone. If that underlayer washes out or gets soft, what's going to happen to the asphalt? It's going to break down, and you're going to get a what?
Sinkhole.
A pothole. Yeah, exactly. So you're going to get a pothole, and that is what arthritis is. If the cartilage doesn't have a supportive bone underneath it, the bone is soft, it's going to start to break down, and you're going to get a pothole, which is a more severe form of arthritis rather than just slowly wearing down. And so the only way to see if these soft spots or stress or microfractures, we like to call them, are there present in the bone is by getting an MRI. You can look at an X-ray and you can see the bone nicely, but you can't see if there's any stress or microfractures because it's microscopic. So an MRI is going to show that. So a lot of people think, oh, I need to get an MRI to see if there's a cartilage tear. Yes, it will show a cartilage tear or a ligament tear, a sprain, an ACL tear, things like that. But we especially love to use MRIs, especially if someone has arthritis and we already know their cartilage is going to look terrible, or at least part of it is. But we want to look at the underlying bone because if that's an issue, that's something that we need to take care of and try to reinforce and firm up so that the cartilage that's remaining doesn't continue to break down. And so the bone is very, very important. Now, the bone also has millions of pressure sensitive nerve fibers. So as the bone breaks down faster than the body can heal itself, you get these little stress or microfractures, and bone has millions of pressure sensitive nerve fibers, so it hurts. So most of the pain from arthritis actually comes from the bone, not from the cartilage. Cartilage doesn't have any nerve fibers in it. Now, if the joint gets inflamed and swollen, the joint casing or capsule will stretch and give you some pain. The meniscus cartilage is attached to the capsule, the casing around the joint. If that's torn, it can cause pain. But cartilage just in and of itself does not cause pain. So the wear of the cartilage isn't going to give you pain. It's when the stress starts going to the bone or the joint starts getting inflamed and swollen that you're going to notice pain.
Gotcha. Yeah. So you talked about getting an MRI to view that part of the bone. Is that just like you could just get that at any typical MRI?
Yeah, so that's another great question. An MRI stands for magnetic resonance imaging. So it's using magnets and not like an X-ray uses radiation. And ultrasound, we also use ultrasound a lot of times, that uses sound waves. So the MRI uses magnets, and I'll simplify it. Like you can spin the magnets at different speeds and get different views of the knee. But what it really does is it slices through the knee electronically, kind of like a cold cut slicer. So you get a bunch of different images. So you can look at the joint or whatever body part. It could be a heart, lung, liver, whatever. You can look at the body part in a three-dimensional manner. Whereas on an X-ray, it's just two-dimensional. And even an ultrasound is two-dimensional, but you can look at it, an ultrasound, you can look at it moving live. You can actually see it moving. The X-ray and the MRI, most MRIs, I mean, there are some dynamic MRIs, but most MRIs are and X-rays are static images, meaning they're just a point in time. So anyway, the MRI uses magnets to look at the joint and recreate a three-dimensional view of it. And so it's really good for looking at things that X-ray doesn't show. So it's good for looking at the cartilage. It's good for looking at the soft tissues, cartilage, tendons, ligaments. Ligaments connect bone to bone, like you sprain your ligament in your ankle that frequently, or you can tear the ACL in the knee. Anterior cruciate ligament connects the thigh bone to the shin bone. It's the main ligament that prevents the knee from giving out. And it will also look at muscles. It can look for fluid. But what people sometimes don't realize is, yes, X-rays are probably really best for looking at like kind of like the structure of the bone, and even a CAT scan is a three-dimensional X-ray. But the MRI is kind of underrated as to what it can see inside the bone. But it can detect fractures, but it can also detect microfractures before they've gotten to the point where you can see them on a regular X-ray. And so the MRI, if you use the special sequences that are specifically to look at the bone, we call them stir images. Those will show those microfractures or stress microfractures or soft spots way better than any other of the other type of imaging. And so what we specifically are looking for that, we have our own MRI scanner, and we have certain software and programs that we test to look for all those other things I talked about, but also specifically to look to see if there's a bone problem. Because if there is a bone problem, there are ways we can help um, repair it or reinforce it. And that was what I was talking about. If you can repair, reinforce that, it's going to support, it's going to give continued support to that cartilage over the top. So MRIs are extremely useful for looking at the underlying bone under the cartilage to see if there's a problem there, to see if we can repair that.
Right. Yeah, because obviously, if you don't repair the underside, right, it doesn't matter how much work you do to the top side.
Exactly.
It's ultimately going to fail if you don't reinforce it, right? So,
And
um,
that's exactly why to your point, that's exactly why people might say, or doctors sometimes say, well, I gave them a cortisone injection in their knee, and I gave them the gel injections in their knee, and I gave them PRP in their knee, and they still, even I did stem cells in their knee. Okay. But you didn't look at the bone underneath, and that bone is soft, and that bone is a problem. And if you don't address that, all the stuff you're doing inside the knee, it might help a little because there might be some inflammation in the knee swelling. It's going to help. But if you don't take care of that problem in the bone, it's gonna fail ultimately. And unfortunately, a lot of doctors aren't trained in that to look for that. They don't understand what that means, and they don't know how to treat it. And it's just something I learned through years of research and experience and traveling the world, really, too, to be honest with you.
yeah, yeah, that's awesome. Um, you also touched on meniscus tears a little bit, so I'm going back to my list now. One person asks, how would I know if I have a meniscus tear? And obviously, I'm going to preface this with this is not medical advice that we are giving. This is just a general information session as, um, you know, if people want to know what that would maybe feel like symptomatically, what would definitively get to the diagnosis of that if that were the case, just kind of giving an overview of that process.
Yeah, no, you literally just read my mind because I was just going to say, first of all, the questions are great unless you've modified them somehow, which is fine to do if someone asks a specific question about themselves. But like these questions are great because nobody's asking, hey, I have a tear of meniscus in my knee. What do I do? We can't obviously answer that on a forum like this, but the questions have been great because they're all general questions, but they might apply to you. And so yeah, use them in your own head to understand things better. But yeah, if you have your own doctor, then obviously you want to ask them the specific questions regarding your own knee. Or if you wanted to ask me, you'd have to come in the office. We'd have to do it that way. But so I totally agree with what you just said. So the question is, how would I know if I have a meniscus tear in my knee? And again, what is the meniscus? Well, the meniscus are the little two semicircular shock absorbers. Next time we do this, I'll have some models. We'll show the models, but this is live, so it's not like we can put images. Maybe we can figure out how to put images up as we're doing this somehow when we get more of a production team. This is day one, so we'll see. Someday you'll be able to put a picture up and I'll be able to, yeah, that's it. So anyway, we have two types of cartilage in the knee. We have the cartilage on the end of the bone, which looks like the white on the end of a chicken bone, tread on a tire. When that wears out, that's what arthritis is. And then we also have the meniscus cartilage, two little semicircular shock absorber cartilage in between the femur, the thigh bone, and the tibia, the shin bone. And those two little semicircular meniscus cartilages are very important for um, actually the health of the fluid of your joint, believe it or not. So that's one of the big things they do. Secondarily, they're also important for stability because the thigh bone's round and the shin bone's flat and they don't really match up real well. So the meniscus cartilages help them match up better and it helps for stability. Now, the meniscus is usually the type of cartilage you hear about, like when an athlete tears the cartilage in their knee and they need to have arthroscopic surgery. It's usually not the cartilage on the end of the bone that quote unquote tears. You can have an injury in sports that injures that, but it's usually the meniscus. So when the meniscus tears, it doesn't have a very good blood supply. Only where it attaches to the casing around the joint, the capsule, does it have a good blood supply. So if it tears in that area and it's a small tear, very small, less than a centimeter, it may heal on its own or with a little help from us with a PRP or bone marrow shots or stem cells or those things. If it's torn in the inner third where there's absolutely no blood supply, it's almost never going to heal. So even if we went in there surgically and sewed it together, which I'm a surgeon as well, and I do a lot of minimally invasive arthroscopic surgery, even if you go in that inner third area where there's no blood supply and you sew it together, it's probably not going to heal. Although we're getting more and more aggressive nowadays with the biologic treatments and the stem cells and the PRP and all that. So it doesn't have a very good blood supply, so it doesn't usually heal well on its own. And that's why it will give you symptoms because now it starts flopping back and forth or it's unstable. So either it starts pulling on that joint capsule or that casing around the joint because it's torn and it gives you pain from that. Or what happened in me, I had that happen to me. It starts flipping in between the two bones and causing your knee to lock or catch because it gets caught or pinched in between. A, that hurts. And B, you feel like your knee's locking up. And sometimes it does lock and you have to kind of shake it free. Or there's rare occasions where it locks and you can't get it unlocked. We have to take the person to the operating room and we have to go in there arthroscopically and try to flip that piece that's torn back over and hopefully repair it. Or if it's not repairable, just trim out the torn part, but leave the rest behind. In the old days, like the 1970s and even the 1980s and before, they would make a big incision, take the whole meniscus out. Oh, you'd feel great for a while, but when you lose your shock absorber, now that cartilage on the end of the bone is going to really wear down a lot faster, and you're going to develop arthritis a lot faster. So we try to preserve it if at all possible, but the symptoms you're going to feel might be pain, clicking, swelling, locking where it gets stuck, um, tenderness to touch. Any other things you can think of? Because you've obviously seen a bunch of these as well. I mean, any other things? Giving out, meaning buckling, not necessarily, but
Feeling
locking is,
unstable, maybe
yeah.
another
I
thing
mean,
that
if it's catching or locking and it's swollen, it's probably a meniscus tear. It could be something loose floating around too. There's these things called loose bodies. Sometimes a little piece of cartilage, even a piece of meniscus, might break off and start floating around inside your knee. That'll lock your knee up, and that'll sometimes feel like a meniscus tear. But the best thing to do is to get in to see somebody who deals with that. Orthopedic surgeons, especially sports medicine orthopedic surgeons, we deal with that stuff all the time, and that would require, you get an X-ray because there could be a little thing that broke off, and you can see it on the X-ray sometimes. Also, an MRI is going to show that. It's also going to show a meniscus tear, which an X-ray won't show. It's going to show a lot of other things that an X-ray won't show either. So all those things are important. Sometimes even an ultrasound is important because you'll see that loose thing floating around in there. You'll definitely see fluid. You can even see a peripheral or an outer meniscus tear, but you can't see a deep meniscus tear with an ultrasound. So all those things combined, all the pieces of the puzzle, the history, we can usually figure out if it's needs surgery or doesn't need surgery. Because the other thing, we might as well get to this, is that a lot of people maybe in their 50s, 60s, 70s. They just have knee pain and maybe some knee swelling. They're not having any locking or any mechanical symptoms giving way, unstable symptoms, anything like that. It's just pain. And they get an MRI. Their primary care orders an MRI, and they get sent to us, and it says, I have a meniscus tear and I need surgery. And that there's different types of meniscus tears, just like there's different types of snowflakes. No two snowflake looks the same. No two meniscus tears look the same, but there's general categories. So if you have an unstable piece that's flopping back and forth, yeah, that's going to usually need surgery. But if you have wear and tear, just like the cartilage on the end of the bone wears down, well, the meniscus wears down too. And as it wears down, it kind of degenerates and gets kind of frayed and it can sometimes break off and things like that. But most of the time, it just kind of just starts to wear out and wear and tear. That doesn't always need surgery. That is more of a degenerative tearing as opposed to necessarily a discrete tear. And the good news is there that most of the time that doesn't need surgery, and that's really more of a degenerative process. So that's where the regenerative medicine, the PRP, the bone marrow, the stem cells, all that stuff comes into play. And you asked about PRP earlier. I think I neglected to mention this, but studies have shown there's at least 37 studies at this point, at least, that show peer-reviewed high-level studies that show that PRP is better than cortisone injections. It's better than gel injections. It's a lot of times better than standard physical therapy, and it's better than even arthroscopic surgery for degenerative meniscus tears or for arthritis. So you don't always need surgery when you have a quote unquote meniscus tear on an MRI if you don't have mechanical symptoms, and the research bears that out.
Okay. Awesome. Well, thank you. I do have one more question that I think we'll be able to get to. We got a few that we're going to push off to next Wednesday, but this, I think you'll love this question. Does knee repair, not knee replacement, work if I have bone-on-bone arthritis?
First of all, yeah, we probably should talk a little bit more about like what knee repair, not knee replacement is when we have more time. Because we probably got about 5 minutes left. But knee repair, not knee replacement is a trademarked program or process, that system that we developed and I had trademarked back in 2021. But that's a whole long story. But I guess the main issue or main point about knee repair, not knee replacement is it's a program and there's general principles. And some of the stuff that we're talking about, regenerative medicine, weight loss, anti-inflammatory diet, metabolic fitness, resistance training, building muscle, is all part of that program. And so knee repair, not knee replacement is a multifaceted thing. But to answer the short answer to that question is absolutely it can help someone who has bone-on-bone arthritis. It is not going to make that bone-on-bone arthritis back to when that person was 18 years of age. We can't do that. Nobody can do that. I don't care where you go throughout the world. I've been all over the world. No one's doing that yet. If you could do it, everybody would be doing it, right? It can't be done yet. But we can perhaps, we talked about, I think this has been a really good session. You might be able to grow a little bit back. You'll be able to hopefully optimize the cells that are still in there to produce more matrix, get the swelling down, get the inflammation down, get the muscle stronger, get the fat out of the body, maybe lose some weight if you need to lose weight, anti-inflammatory diet, all these different things. And then including the regenerative, whether you got to take care of the bone, because a lot of people have bone on bone and have pain. You got to get that MRI and it's going to show the stress microfracturing in the bone and just taking care of that. We have a few minutes here, but there's an amazing study. Dr. Philippe Pernigot, orthopedic surgeon in France, late 90s, early 2000s. He has 140 patients, and his theory is that as we get older, we have less good stem cells in our arms and our legs and our extremities, but we still have really good stem cells in our back, our spine, and in our pelvis. Now, no one wants to take stem cells from the spine if they can help it, but the pelvis is right underneath the skin in the back here, not our back itself, but in the lower area here. And the pelvis is very accessible and it still has a lot of good stem cells in it. And stem cells are cells that can turn into other cells. But as we also earlier talked about in this hour, they can help tell other cells what to do. and help remodel the inside of the joint. So it's more, we'll get into this some other time too. We're really remodeling the joint. We're not necessarily making it a brand new joint, like making it brand spanking new, but we're remodeling it, making it better, just like that show Fixer Upper. The house looks crappy, feels crappy, doesn't function well. It has a lot of quirks to it. Chip and Joanna come in, they can do the work themselves. They're kind of like the boss cells, but they tell their team what to do. Their team comes in and their team remodels the house. So now it looks better, feels better, functions better. It still has a few quirks, but not as many as it used to. It's still the same house, but it works and functions a lot better. That's how knee repair, not knee replacement works. And so we'll get into that more at some time in the future. But the answer is yes, it can absolutely help plenty of patients who are bone-on-bone arthritis, and we've done that multiple times. And regarding Dr. Hernigo, he had 140 patients. They had really bad arthritis in both knees, bilateral knees. So they were told they needed a knee replacement in both knees. You need a knee replacement in both knees. So he said, okay, we're going to do a knee replacement on one knee, and we're going to do the stem cells on the other knee, and we're going to inject it into the bone where the problems are, where these stress microfractures are. So they had a minimum follow-up of 10 years, 10, maybe some of them 15 and 20 years. And at the end of the day, 82% of the people who got just the little poke holes, the little shots of the stem cells into
Yep.
their bone, never needed a knee replacement for 10, 15, 20 years. So if I told you you have bone on bone arthritis and you ask me that question and I tell you if we just did that, and we do more than that, by the way, if we just did that, you got an 82% chance of never needing a knee replacement for 10, 15, 20 years. Would you take that? You
Absolutely.
can ask that. I don't know if they're on the. You can ask them that question or right back. But that's the question. That's the question. And we do more than just that. So we do a program. That's part of our program. Just doing that. But that study was an amazing study. And those people, 82% didn't even need a knee replacement. And by the way, the people who got, I mean, the other knee, because they all got at least one knee replacement. They all said their non-knee replacement knee felt more normal. It functioned better. And the knee replacement knee, 15% of those in that 10-year frame needed another one. So they needed two huge surgeries. And because metal, plastic, and cement wears out. Once you get metal, plastic, and cement, you've got it for life.
Yeah, for sure. For sure. All right. So definitely have a few more questions to ask, but we're going to push them off towards next week. Everyone, make sure that you submit your questions. And Dr. P will do an awesome job as he did today, answering all of them. And
Hey, thank you, Facebook group. You guys are awesome.
yeah, they
Those
were
are
they were
great
killing
questions. Yeah,
it.
those are
All right.
awesome. And school
Well,
group, thank you. We're just started that, but the Facebook group with coming with a lot of questions. I love it. Bringing them. Thank
yeah,
you.
absolutely. Well, we'll see everyone next week at 9 a.m.
Great. Thanks, Adam. Appreciate it. Great job.
Absolutely. Have a good one.
You too.